Welcome back to Plastic Surgery Decoded, the podcast designed to help you better understand plastic surgery. We take the mystery out of it in plain language. You'll find it interesting and useful whether you are already planning a procedure or you're just curious. I'm your host, Dr. Regina Nouhan, and we are now into Season 5 of the podcast. After you listen to this episode, know that you can explore and enjoy many other topics, either through your favorite podcast app or through the website at plasticsurgerydecoded.com. The first 40 episodes, or Seasons 1, 2, and 3, comprise the Plastic Surgery Decoded Classics, with my singular voice covering cosmetic and reconstructive procedures, skincare, and general questions about plastic surgery. The remainder of episodes, Seasons 4 and 5, are interviews with my colleagues around the country to help you learn about the subject. A great variety to choose from. Remember that this podcast reflects my experience and opinion, as well as those of any guest interviewed. It is not intended to provide medical advice, nor is it a substitute for a formal consultation with your physician. So come along with me as we explore this ever-growing world of plastic surgery. Let's go! Craniofacial surgery. Sounds so technical, and it is. But it can also be rendered into concepts that are understandable and which actually impact many of us, not just those with congenital problems of the face and skull. From the person who needs restoration of basic facial functions to the person who wishes cosmetic facial rejuvenation to combat aging or to correct an issue they've dealt with for a long time, craniofacial concerns and the addressing of underlying bony structure can be critical. Enter Dr. Natalie Plana, craniofacial plastic surgeon who brings skill, creativity, and enthusiasm to her growing practice. In this episode, she breaks down concepts and gives us a window into what a beautiful subspecialty this is. Here we go. With me today is Dr. Natalie Plana, a plastic surgeon in private practice. In addition to her plastic surgery training, she did a craniofacial fellowship at NYU, and she has many publications and presentations to her name. A rising star. Welcome, Dr. Plana.
Thank you so much for having me. It's a real honor to be with you today, and I'm looking forward to a great combo.
Yay, that sounds wonderful. Perfect. Well, as we start out, would you just tell us a little bit about your practice, where you're located, and what is the scope of your practice?
Sure. So I'm based in Manhattan, New York. I recently joined Hannah Face and Jaw. We are a two-surgeon practice. We sort of offer a full aesthetic and reconstructive continuum of surgery for the face, head, necks, and jaws. For me, my practice scope really sort of narrows in on orthognathic surgery, which is jaw surgery. We can talk a little bit more about what that is.
Sure.
Rhinoplasty, which is nose surgery, chin surgery, soft tissue aesthetics to the face, and cleft care.
Oh, that's great. So your practice encompasses pediatric patients as well, with the cleft work you're doing.
That's exactly right. What's fun about, I think, being a plastic surgeon, and especially being a craniofacial surgeon, is that we don't own any one part of the body. So
Right.
We sort of operate all over, and what that means also is we can operate on a patient of any age. So from 0 to 100 plus. So a lot of my training in craniofacial was in the pediatric population. That was my initial draw into plastic surgery, actually. I had a good opportunity early on to work with some very skilled and talented craniofacial and maxillofacial surgeons. And I thought, wow, this is fascinating. And I was exposed first to cleft care and realizing that, a higher number of children in this country than I knew are being born with a cleft. So probably 1 in 1,000 children in the US. It's a little bit more common abroad. It's closer to 1 in 600 probably. And so, when I was younger, I sort of had heard about Smile Train and Operation Smile and global missions.
Sure.
But I had a poor appreciation of how prevalent it was here at home. Mm-hmm. And I had zero understanding of the complex and beautiful surgical work that can be done to repair a cleft.
Oh, that's so great.
Yes, I have a great passion for treating children with a cleft. And what's cool about that is that you can meet a child, but even before they're born, you can meet their mom when they're pregnant.
Ah, yes.
The child can be diagnosed with a cleft, so you meet them even before they come into this world. You have the opportunity to operate on them as early as 3 months of age, and then that patient-doctor relationship can continue well into their teenage years, and if you want, into adulthood.
That's pretty
There's
wonderful.
a really interesting and intricate surgical journey that can happen throughout. Yeah.
And let me just stop for a minute for our listeners who may not be familiar. What is a cleft? What are you referring to when you say a cleft?
So a cleft is when a child is born with a difference, most commonly along the lip. Sometimes it can extend up into the palate, which is the roof of the mouth. There are some very rare clefts that can extend into different parts of the face, over into the eyes. And the way that the face forms in utero when we're little embryos is there are two sides that sort of merge together and they meet at the midline. And so what happens with a cleft is that development doesn't occur fully, and so there's just one area that is left behind.
Yes, so it's left open, basically.
Correct.
To varying degrees, yes. It can be so devastating to children and their families. Well, we are here to talk about the topic of craniofacial surgery, but first I'd just love to go over the definition of that. How would you explain craniofacial surgery to our listeners? And it is a broad topic.
So craniofacial surgery, sort of by definition, is about restructuring the skull, which is the cranium, and face, which is facial. So when you hear terms like craniofacial, breaking it down sort of gives you a little bit better of an understanding of what that means. And craniofacial surgery is fascinating because it's a very youthful surgical subspecialty. It didn't really sort of start to take shape until about maybe the mid 20th century. And it really arose from, we can sort of pinpoint to one pioneering surgeon. His name was Paul Tessier, who was very bold and decided, what if we move the bones in the skull and the bones in the face to try to address a lot of the deformities and the complexities of patients that were otherwise being untreated or sort of just casted aside from society. And so the people who can really benefit from movements like this are oftentimes children, as we've spoken about, who are born with differences in their face, and most commonly those that are born with underdevelopment, typically of the bony side of the face, and then the soft tissue and a lot of the musculature, nerves, skin over top of that will sort of take on a different shape. So children with congenital, or what we call birth differences, a lot of traumatic injuries to the face, car accidents, military kinds of injuries during combat, and even sort of just burn injuries, different sort of traumatic injuries. And then individuals who are left with defects in the face after cancer surgery. So when someone has a big tumor in their face and they have a big resection, moving the bones and the soft tissue in a pretty dramatic way can have a profound effect on their form, their appearance, and their function, how they're able to sort of interact with the world.
So you mean like speaking and eating and those kinds of functions, or what are you talking about?
Oh, yeah, no, it's exactly what you said. Speaking, having a good auditory sense, being able to chew, eating normal foods, opening and closing their eyes, making sure that they can see well. These sort of deformities, whether they be congenital, traumatic, they can oftentimes sort of leave patients void of the structures that can carry out normal daily functions that you or I may sort of take advantage of. So I think as a specialty, craniofacial surgery positioned itself to be quite valiant in pushing the boundaries and saying, how can we reconstruct elements of the face, understanding the face not sort of in compartments, but as a system, as a whole.
Very good. Yeah, there is a tendency, I think, in any surgical specialty to really compartmentalize areas of the body, and to look at the gestalt of the whole picture is really of best benefit to the patient, certainly. So
yeah, absolutely.
And I think a lot of our listeners are used to connecting congenital deformities with birth defects, but I hear you saying birth differences. Could you explain what is considered acceptable these days in terms of how we address those issues or how we label those issues?
Sure. So I hope this answers your question, but I'll say this. I really commend the younger generation for establishing a movement that is accepting of people for who they are, and accepting people for who they want to be, right? And where you sort of label a facial difference versus a defect versus a medically challenging or medically complex alteration of the face, it's a continuum, right? And where you sort of sit on that continuum is determined by the society that you live in, the culture that you sort of follow. And I really think, having worked with kids up until this part of my career, I think they do just a fascinating job, especially like teenagers and kids in their young 20s now, of embracing who they are for themselves and trying to put forward who they want the world to see them as.
Yeah.
And where that fits, or where I would like to fit in that as a surgeon, is to say, what are things that I can offer you that can bring out the part of you that you want the world to see? Whether from a prior surgery, from a lip repair, your lip looks great, but you really dislike the scar, and you just want to get that scar improved. Or someone who just doesn't have the ability to, they were born perhaps with a facial palsy, and now they're looking for someone to give them a little bit more animation in their face so they can smile out into the world. And that extends well into the aesthetic population, which is probably the bulk of the kinds of patients that I'm seeing now in practice. And those are patients who may not be labeled by somebody else or by society as having a facial difference, but to them, they would like to optimize their appearance in a way that looks a little bit closer to what they would like and their ideal. Yeah. And I think that I would not shy away any further from them to be able to deliver what is possible. And yeah. We're starting to see that a lot with orthognathic surgery. That's sort of my drive, and that's my real passion and motivation.
Yeah, that's great.
And to explain to the listeners a little bit, orthognathic surgery is surgery to the jaws, and it's most conventionally utilized for patients who have, their bite might be off, and that could be for a number of reasons.
Like an overbite or an underbite or those kinds of things you're talking about?
Yeah, that's exactly right.
Or a crossbite.
A crossbite. And so in my training, I worked a lot with children who were born with a cleft, and oftentimes the surgery that we're offering to them as they start to grow, because of scar tissue and underdevelopment, they're left with a really, really big underbite. And these kids just want to be able to smile really cutely in their school photo and bring their lips together to be able to give their teenage crush a nice pooch on the lips, or just to be able to swallow food without drooling. So there are different sort of indications or desires for this. So the jaw surgery will essentially move segments of the jaw so that the teeth can come together and you can have a nice good bite and your lips can come together, and there's a good function to that. But what I learned in my training is that the aesthetics and the appearance of someone's face can be profoundly changed as you're moving the jaws around.
So by moving, you mean advancing forward or pulling back, or those the kinds of things you're talking about?
Yeah, that's exactly right. And sometimes it may seem like a simple sort of, we're just moving the top jaw forward or the bottom jaw back, but it starts to get very complex and very fun because it's all three-dimensional. And so we're rotating in different dimensions. Sometimes we're sort of pitching things in a downward direction or upward as we're moving forward. Right. We're shifting side to side. Some patients may see a little bit of an asymmetry between the left and right side of their face. They're not sort of quite exact, and so their smile may be canted up one side. So freely moving the jaws around gives us a total control of where we want them to land. And so now we can let them land not just in a position where the teeth come together and your bite can be optimal, but now the whole face can sit in a more balanced, more appealing position. So there's a lot of aesthetic gain that can be achieved through movement of the jaws.
Yeah, that's really great, and that's a great explanation. And you're right, most times it's not as simple as just moving something a little forward or a little backward. There's so many other directions and dimensions that have to be considered, and the effects that the bone surgery will have on the overlying soft tissues and the function of those tissues and the appearance. So that's really great for people to hear about. Well, as we're talking about craniofacial surgery, we've talked a little bit about subtypes or categories, congenital differences or differences from birth, cancer resection we mentioned, and even reconstruction after an injury. Could you just kind of go through those quickly and just give us a little example of each of those potential cases and what might be involved and what might be required to get the person to the place that they want to be?
Sure. So I'm going to start with congenital because that's sort of my favorite and where I gravitate towards. And I'll use the patient with a cleft as an example there. So a baby is sort of diagnosed with a cleft lip and a cleft palate, which is sort of an opening.
So there's a split there.
Yeah, there's a split between the lip and the roof of their mouth. And there are probably about 8 to 10 procedures that baby's going to need to undergo from birth to the time that their face is done growing.
It's not just one and done.
It's not just a one and done, and it's onerous onto the family, and it's challenging for the patient themselves, but it's very rewarding as a surgeon because you can see these children grow up, and you're sort of battling with time as a surgeon because you want to be able to correct as much as needed early on so that the split is closed, the lip is sort of now as one and not split into two, but you don't want to accelerate any of these procedures, meaning you don't want to do them too early because sometimes you need the child to grow a little further before you can intervene onto the next step.
Yes.
And at other points you sort of need the face to start to develop. So for example, you need to wait for some of the teeth to come in order to do a little bone grafting to the bridge of the bone in the top jaw, because sometimes that cleft or that split extends up into the bony segment where the teeth come in. So if there's no bone, no tooth will come in. So we have to wait until they're probably about school age before we can put a little segment of bone into that piece. But again, timing is important. Timing is everything, because if you wait too long, then that bone won't take, the tooth won't develop, and you'll sort of lose that opportunity. Mm-hmm. And then you want to wait until the face is completely stopped growing before you want to do any major surgeries like movement of the jaws or refinement of the nose, for example. You don't want to sort of intervene too much on the nose, especially functionally, until the nose is completely done growing, so you have exactly a good understanding of what's in front of you before you start manipulating any kind of tissue or rearranging things.
Sure.
So that's an example of a congenital indication for surgery, sort of my space.
Gotcha. So if you have a bone defect, you're trying to maximize potential for tooth growth, but if you have a grafted bone, are you expecting teeth to grow in the graft or no?
Yeah.
You are?
Yeah, so...
tell us about that.
Sure, so that's why timing is critical. I'm actually glad you asked that question. Timing is critical, and multidisciplinary collaboration is critical, because children who are born with a cleft are not followed just by their surgeon, but it's an entire multidisciplinary team that includes an orthodontist, a speech pathologist, nutritionist, psychologist, social worker, because it's sort of an all-encompassing care. Mm-hmm. And so it's actually the orthodontist who follows the patient, typically when they're around 7, 8, or 9 years old, is the time that we call their mixed dentition. So they're starting to lose some of their baby teeth and some of their adult teeth are starting to come in.
Yes.
And so that is the time when the orthodontist will get a panorex and tell you, okay, now is the time to strike. For us as the surgeons to come in, we put bone graft into that space. And the bone that we graft in there, we need to allow to heal and to integrate and time it well so that when the tooth starts to come in and starts to bud, then there's healthy bone available for that tooth to be seated into.
Nice. Yeah, I think that's fascinating.
The multidisciplinary care, like, I really cannot underemphasize how important that is.
Yeah.
I think that, sometimes we start to get a little bit too narrowed and niche in our arena, but considering, across so many different disciplines and so many different specialties, so I don't think that surgery is specialty specific. Many of us, we're proud of where we come from, but we sort of ignore that we can learn from others who are in adjacent specialties with a lot of overlap.
That's so true. We have to check the egos at the door and just be open and receptive to learning and collaboration. So that's wonderful. And cancer resection, we mentioned, in reconstruction after an injury.
Some cancer resection and trauma. So the most common cases that I see of patients who had any kind of cancer or tumor to the face is patients who had skin cancer. And so oftentimes they'll have a special procedure known as a Mohs procedure performed by their dermatologist. But Mohs in and of itself is a great procedure because it really, in real time, under a microscope, you can remove all of the skin cancer and preserve as much as the healthy tissue around it as possible. Yes. In the olden days, we used to just whack out a whole sort of segment of tissue, and a lot of healthy tissue would go so that we can ensure that all of the cancer was gone. But now the dermatologists have really advanced it to the point where they're looking slice by slice under a microscope to make sure they take all of the cancer out but leave as much as the good healthy tissue.
Sure.
And you want that in the face because every sort of millimeter counts.
Yeah, it's hard to replace.
It's really difficult to replace. But as a plastic surgeon, I can dial up my creativity senses and start to move around local tissue in the face to try to close up or patch up some of these defects that are left behind from the cancer removal. Mm-hmm. And that overlaps a lot with the aesthetics because especially in the middle and lower parts of the face, a lot of the techniques and maneuvers that we do sort of utilize, it overlaps a lot with what we would do for a facelift, for example. So moving tissue and mobilizing tissue around to close that kind of gap, it really sort of lends itself well to being able to address some of these things for some patients.
And then what about traumatic injuries? Thoughts about that or similar?
Sure. We see a lot of traumatic injuries that are isolated to bony fractures in the face. Mm-hmm. We see a lot of fractures to the jaw, to the eye sockets and facial skeleton, but understanding the bony framework is going to be important to see how the soft tissue that overlies it will sort of change.
Yes.
So that's really important. I'm going to go back to plug one of my mentors because early on, even before I became a plastic surgery resident, I did research with Eduardo Rodriguez, and he is a real pioneer and an innovator when it comes to complex facial traumatic reconstruction. He sort of took all of his knowledge in treating fractures to the face and even injuries to the soft tissue over top, and he's now has taken that up to the pinnacle of it all in facial transplantation. So
yes.
Those are patients with severe facial disfigurement whose quality of life has been completely destroyed by their injury, and there are no other options of moving tissue from one part of the body or another. These injuries are just too severe, or those options were explored and it's just not enough to get them to the appearance that they should have. Yeah. So these individuals, they're rare cases, but will rely on a transplant from a cadaveric donor to transplant the entire face or sometimes parts of the face to be able to restore a new appearance and give them a function. So oftentimes these are patients who are unable to open and close their eyes, so they can't protect their eyeball. Sometimes they have no breathing capacity. It's really devastating. They can't speak. They have to sort of be fed through a feeding tube that goes directly into their stomach. They oftentimes have a tracheostomy, which doesn't allow them to go into any kind of body of water, so they can't go in the pool or the ocean.
Oh, yeah.
So a facial transplantation is a real life-saving procedure for these individuals.
That's amazing. Well, we actually did an episode about face transplants a while ago, but it is a fascinating topic, and I'm glad you brought it up.
It's a special procedure that I think it has a long way to go in terms of really being able to maximize the number of patients that it can help and the way that it can help them. I think a lot of that will come from the immunology, but it's pretty cool what craniofacial surgeons can do.
Yeah, I love that. Well, you've touched on this a little bit, but is craniofacial surgery mostly reconstructive and for functional restoration? How can the procedures or the outcome of the procedures impact a patient psychologically as well as functionally?
Sure. So in the practice that I work at now, we have a real philosophy that the aesthetics of any surgery, regardless of the indication for them, is pretty much inseparable from any kind of form or functional goal that we're trying to achieve. So aesthetics really lies at the forefront of it all. Many of our patients are purely aesthetically driven, and so we actually don't change any of our philosophy when we're moving segments of jaws or trying to, lift segments of the face. So my approach to practice has really tried to focus on optimizing aesthetics as your primary goal. Secondary only to, keep safety, right? Making sure that patients are safe. But I think that changes to somebody's face can be remarkably impactful on their psychology, on their self-confidence, on the way that they present themselves to the world, and therefore the way that the world will perceive them and interact with them in return. And so what we've really tried to do in our practice is, we are trained in all sorts of elements of facial reconstruction and facial aesthetics, and now we're really trying to put together the best pieces of it all and try to integrate hard tissue, soft tissue, bite, form, function, and really merge it all into one to push forward an agenda that patients can see will really lead to the highest quality aesthetic outcome possible.
So you're really customizing the treatment they get for their individual situation, using all those tools, the skills you've acquired, and the things that you've learned.
That's exactly right. So as you know, plastic surgery is not an algorithmic surgical specialty. We learn everything that's principles-based. And many of my mentors now perform surgeries that they were never taught to do, but they're able to do at a very high level because they were provided the tools and the way of thinking that can allow them to create something new and something better than existed before. So we don't sort of just repeat what was indoctrinated into us previously.
You're not stuck on certain things. This is what I learned and this is all I can do.
Exactly right. Nor would anyone want that in a surgeon who is affecting appearance and has control over aesthetic changes. Mm-hmm. So thinking outside the box is really important.
Yeah.
And what we've tried to do is there are so many principles that, focus on jaw surgery just for the bite and just for, moving things together. But I think really taking that multiple layers deeper and saying, how do we get the best aesthetic outcome that we can for these patients? Mm-hmm. And then, many of our patients, their bite is fine or they have, very good function, but they really want to optimize their aesthetics as much as possible. And so what we try to do is integrate from all the different specialties who have taught us in our training and now culminate that into something that is new and somewhat unique. So I think that aesthetic orthognathic surgery or aesthetic maxillofacial surgery, as we would say, is a budding field that is not tied to any one discipline, but now bringing together principles, founding ideas from all different areas and putting it together into something that can move things forward.
Well, you're kind of touching on an interesting concept. I'd really like to pursue that for just a little bit. Beyond the reconstructive side of things, how might craniofacial concerns impact cosmetic surgery? What is the importance of the underlying bone structure? And you talked about that a little bit, but how does it impact aging and surgical efforts towards aesthetic rejuvenation?
Sure. So I'm sort of subscribed to the thinking that, I think I mentioned this earlier, but the face isn't just the sum of its parts. It really functions as an entire system. And so I think that as a surgeon, when I'm considering alterations to the face, whether it be for a reconstructive pursuit or an aesthetic pursuit, I think that you have to look at the face as one large comprehensive piece. And so the bone really is the scaffolding of the face. And that's really going to set the structure and the foundation for everything that sort of lays on top of it. So I lean much more towards the bony work because I'm really comfortable with it and because I understand how much of a difference a small movement in the bone can make. As the bones start to move, the overlying soft tissue, you can almost think about it as like drapery or upholstery to the underlying bony structure.
Yeah, it's really fascinating. I think a lot of people don't really understand that concept or appreciate that, but it is so true that your cheeks look the way they are, to some degree due to the soft tissues but it's mostly from the underlying bony structure, and your jaw looks the way it is and functions the way it is because of the bony structure.
Right. And some people have just the most beautiful, impeccable skin and soft tissue, and they just have the slightest weakness at the very tip in their chin. Mm-hmm. And I sort of am of the philosophy that you just want to address the foundation. So sometimes just moving the chin forward and manipulating a little bit so you can get some more projection will give that patient the refined, balanced appearance that they're seeking. And sometimes if it's the bony piece that's a little weak, augment the bony piece. I think trying to stuff elements of the soft tissue with non-bony like material, I'll say, if understanding that the weakness of the chin really comes from the bone, I think that augmenting the bone or moving it into a better position would be the way to go. That's going to give the soft tissue the support that it really needs because the soft tissue is vibrant and brilliant and looks great as it is.
So do you ever do a chin implant on somebody or you prefer bone manipulation?
Oh, it's a great question. I think it's really individualized, and I think it's all patient-centered.
Yeah.
I think it really depends on sort of where the weakness lies, how much of an augmentation that patient may or may not need. Sometimes the outcome could be very similar between the two techniques, but the recovery is a little different. So that patient's going to want you know, to be on camera within the week. And so they would rather have a little surgery that has like the tiniest little bit of swelling. So they'll vouch
Sure.
for a little, an implant rather than, moving the bone. But some patients will need a lot more of a movement, so an implant will get them enough. So it really depends on what the patient's goals are, and not just for the aesthetic outcome, but also the recovery and how to get there.
That makes sense.
One other piece that I'll sort of add to the sort of the bony framework.
Yeah.
One thing that it took me a while to learn and appreciate is the way that the bone changes as we age. So
Yes, let's talk about that.
yes, so many of us, we can see the way that our cheeks, our soft tissue, sort of, our skin starts to sag a little bit as much as we try to defy gravity and natural aging.
Sure.
So we see the way that the soft tissue sort of becomes a little bit more tenuous and starts to droop over time. But what it took me a while to appreciate is the way that the bony skeleton actually ages. And so sometimes it ages by atrophying or not being so thick, and we lose a little bit of bone in certain areas of the face. We see that a lot around the orbits or around the eye sockets. And so now the eyeballs don't have the same kind of support. And so the bags under the eyes that are going to do their own thing because of weakness in the support now is even less supported because the bone isn't as strong as it once was. Other elements in the jawline. So I think that when we're considering aging, it's not just the soft tissue. The hard tissue has a real role to play. And the other thing I'll say about bony surgery is that sometimes we do aesthetic surgery. We oftentimes think that it's really for aging or anti-aging indications, but sometimes it's just to get a little bit of augmentation or get a little bit more of a better contour of something where it should have been. Sometimes we just want a little bit more volume where that never was.
Ah, yes. I think that's a great way to explain it so people can understand. Well, so much of the more involved craniofacial surgery, particularly restoring function and restoring contour of areas of the face that have, let's say, been injured or congenitally were never to the standard that the patient wanted. Often a graft is used or tissue from another part of the body or tissue from the region or tissue rearrangement. That's a helpful thing for the patient's particular problem, but are there times when that tissue rearrangement itself can create some unexpected problems? I mean, it could be donor defects or it could be a new functional problem that's been created.
Yeah, that's a good question. These are really important considerations. We as surgeons can't just focus on the area to reconstruct and ignore subsequent complications that can arise.
Mm-hmm.
You can sort of think, you can't rob Peter to pay Paul, as one would say. So that's what makes craniofacial surgery and surgery in general not just complex, but fun and interesting. So you have to keep your mind attuned to all of these possibilities and play it all out to make sure that even before you operate on a patient or offer them a surgery, you know what those consequences might be. Some consequences can actually be foreseen and are planned. So I'll give you an example of that. In the pediatric population, remember we talked about timing being really important and considering how the patient will grow and develop over a series of years. And so one common operation that I did in my training was for something called craniosynostosis. Craniosynostosis is a condition where children are born with seams in their skull and they're intentionally, by design, left open because the brain will grow at a faster rate than the skull.
That's where that soft spot comes from.
That's exactly right. So there are two soft spots and those seams sort of connect them all. So as the brain continues to grow, the skull can accommodate and let that brain do its normal healthy thing. And so unfortunately in craniosynostosis, one or several of those seams can actually fuse prematurely. So it constricts the brain and it puts a lot of pressure. So that has all sorts of implications on neuro and cognitive development for the child. So one operation that we do is we remove the bone of the skull, we take them off, and then as clever reconstructive surgeons as we are, we reconstruct it in such a way that will expand the volume for that balloon of a brain to have space and be able to breathe and now grow very well.
Yeah, it's such a wonderful, amazing thing that can be done.
It's not a small surgery, and I know what patients and families, the burden that they feel when they undergo it, but it does have a lot of functional improvement for the patients. And so when we're thinking about how to reconstruct it, what we also consider that the bones that we put back together are not going to grow as normally as the bones that were never touched by surgery because there's scar tissue, there's a little bit of constriction from the overlying soft tissue in the scalp. So what we do is we actually overcorrect the amount of volume that we sort of push on for these patients. So in the immediate post-operative period, these young kids who are some of the cutest in the world now have a little bit of a funky shaped head. And that's by design, so that over time they will grow into that skull shape and their brain will have enough space to accommodate for that. So at times there are functional and aesthetic sequelae that result from some of the reconstructive techniques that we undertake.
Sure.
But the benefit of the surgery far outweighs, that small price to pay in the meantime.
Yeah. And the recognized and planned sequelae, not just incidental.
Yes. Yeah.
Gotcha. Well, we have just been talking about so much cool stuff, and I think people are going to be thrilled with all their new knowledge here. I'm curious if there is some new technology allowing us to accomplish more these days, compared to back when I was in practice. I'm curious what innovations might be present in craniofacial techniques or options, or what would you love to see developed in the future?
Sure. So probably the most exciting innovation currently has been something called virtual surgical planning. So what this allows us to do is we could take a CT scan of the face and we upload it onto the computer. And it's almost like a gamification of surgery. So digitally and together with an engineer, we can plan all of the cuts and movements of the face and skull in a way that is customized to that individual patient. And we can make these movements and adjust them accordingly to achieve the endpoint that we're looking for. So
cool.
Yeah, it's a lot of fun to do, especially when we're thinking about jaw surgery, because oftentimes we're moving both of the jaws together. Sometimes one jaw gets split. The top jaw can be split into different segments. So there are a lot of moving parts.
Sure.
And being able to do that virtually under the safety of a computer, where if you overshoot it in one direction, you can just, push it back and there's no sort of consequence to that. But what that then allows us to do is we can have an established and agreed upon endpoint of the surgery, and then we can 3D print hardware to keep those bones into the place that we move them to. So let's say, for example...
Perfect. Yes.
Yeah, so if we wanted to augment somebody's chin, for example, so we make a little cut in the chin, we move it forward and down, and we get it into the exact position that we want. What we can do from there is 3D print a nice little plate that sits flush to the bone and keeps that segment of bone right where we want it. And that's only existing for that patient and only for the movement that we planned for. So What it does then is it takes a lot of the thinking away in the operating room, because once we have those custom plates, we move the bones and it will only fit to the plate where we want that bone to sit.
So amazing. It's just really awesome.
It's great. And the cool part too is that now you can have the patient's input into the surgical planning, because once we plan it on the computer, then we can have a conversation with the patient and say, this is what we anticipate the outcome will be. These are the movements, and this is what we'll think you'll look like. Is this in line with what you were hoping to achieve? And so the patient now will have a little bit more input of saying, well, I didn't want this much projection, or this is a little bit too much for me, or no, come on, give me more. Let's keep moving. And even if they agree with the plan that we set outright, now the patients have a visual of what their surgery can look like. And so when they come in day of surgery, they can feel a little bit more reassured and comfortable with the surgical plan.
Yeah, that's just fantastic. Progress. Well, Dr. Plana, you have just been wonderful today. Thank you so much for sharing your knowledge with our listeners. I wonder if there are any lasting thoughts you'd like to leave with the listeners about our subject today or about plastic surgery in general.
Yeah, I think plastic surgery, and in that I'll sort of be inclusive of reconstructive surgery and aesthetic surgery, is a field that brings a lot of joy to me personally, but I think is really expanding in a way that is embracing new technology. It is touching a much greater number of patients' lives and making real differences. And I'm really excited to be a part of it. And I think that I'm more excited to see where the field goes, because I think this is only the beginning.
I love hearing that. So wonderful. Thank you, Dr. Natalie Plana. Yeah, really appreciate you sharing your time and expertise with us today. Take care.
Thank you so much.
Well, that's our show for today. Hope you enjoyed it and learned something too. Don't forget to subscribe, rate, and review. Please share this podcast with someone else who might be interested. And while you're at it, check out the podcast website for related topics to explore. It's www.plasticsurgerydecoded.com. And as always, thank you for listening to Plastic Surgery Decoded.